Rheumatological diseases. An immunological threat for lung. Part 3. Dr. Jalal, Mohsin, Uddin, M.B.B.S, D.T.C.D, F.C.P.S, Pulmonology. Part 3. Chest diseases related to polymyositis, dermatomyositis, Sjögren syndrome, M.C.T.D, ankylosing spondylitis, polymyositis and dermatomyositis with pulmonary manifestation. In new polymyositis and dermatomyositis patients, a recent study found that as many as 2/3 had signs of interstitial lung disease, even though all the patients were in early stages of myositis. Polymyositis and dermatomyositis patients seem to have about the equal risk, and the disease is rarely associated with inclusion body myositis. Recent studies show that patients with amyopathic dermatomyositis without the muscle symptoms, are also at risk for lung disease. There are ways that physicians can predict the likelihood of myositis patients developing interstitial lung disease. Patients with anti-Jo1 antibodies are thought to be at a much higher risk, maybe as high as 70%. Detecting the presence of lung disease sooner rather than when symptoms are well established is very important because appropriate treatment may prevent the disease from becoming chronic. Clinical presentations. Difficulty swallowing. If the muscles of the esophagus are affected, may have problem of swallowing, dysphagia. Aspiration pneumonia. Difficulty swallowing cause aspiration of food or liquids, including saliva, into lungs, aspiration, which can lead to pneumonia. Breathing problems. If chest muscles are affected by the disease, may experience breathing problems, such as shortness of breath or, in severe cases, respiratory failure. Most common is non-specific interstitial pneumonia. The prognosis of interstitial lung disease associated with polymyositis is better than that of idiopathic pulmonary fibrosis, since most patients respond to treatment with corticosteroids and immunosuppressants. High-resolution computed tomography showing a bilateral interstitial pattern, with septal enlargement, areas of ground glass opacity, reticulation, and traction bronchiectasis with predominance in the lower lobes. Tacrolimus led to stabilization or improvement in 4 of 5 anti-Jo1 antibody-positive patients with polymyositis. These observations were confirmed in a larger patient cohort of 13 patients. Tumor necrosis factor alpha, TNF-alpha, inhibitors have also been mentioned as promising agents for treatment of both myositis and interstitial lung disease. Sjögren syndrome, SS. Respiratory complications of SS include airway mucosal dryness, also known as xerotrachea, desiccation of the tracheobronchal tree, a variety of interstitial lung diseases, ILDS, non-Hodgkin lymphomas, pleural thickening or effusion, and rarely, thromboembolic disease or pulmonary hypertension. Interstitial lung disease in primary Sjögren syndrome usually present with dyspnea and cough. The major histopathologic patterns included non-specific interstitial pneumonia, NSIP, organizing pneumonia, OP, usual interstitial pneumonia, UIP, lymphocytic interstitial pneumonia, primary pulmonary lymphoma, and diffuse interstitial amyloidosis. Treatment commonly included prednisone with or without another immunosuppressive agent. Except UIP pattern, in other histological pattern, prognosis is better. Lymphocytic interstitial pneumonia in Sjögren syndrome. HRCT scan demonstrates bilateral thin-walled cystic lesions in a random distribution. Also noted are small foci of ground glass attenuation and a few linear opacities. More extensive areas of ground glass attenuation were present in the lower lung zones. Mixed connective tissue disease. Pulmonary involvement is a common complication of mixed connective tissue disease. Nearly 80% of the people with mixed connective tissue disease have some involvement of the lungs. Pleuritis, ILD and pulmonary hypertension are relatively common findings. Up to 2/3 of patients have a reduced diffusing capacity for carbon monoxide, and approximately 1/2 have evidence of restrictive abnormalities on pulmonary function tests. The predominant radiologic abnormality in the chest is ground glass opacities associated with septal thickening with a lower lobe predominance. In one study, 47% of patients with mixed CTD-ILD responded to corticosteroids at a dose of 2 mg/kg/day for 6 to 8 weeks alone, and rest of the patients required cycloserine in combination with cyclophosphamide 2 mg/kg/day. Ankylosing spondylitis. It can affect the tracheobronchal tree and the lung parenchyma. Respiratory complications include chest wall restriction, apical fibrobullous disease with or without secondary pulmonary superinfection, spontaneous pneumothorax, and obstructive sleep apnea. A recent study suggests that patients with ankylosing spondylitis, OS, have a higher incidence of obstructive sleep apnea syndrome, OSAS, that increases with the severity of cervical vertebral involvement. Ankylosing spondylitis is a common cause of pulmonary apical fibrocystic disease. Early involvement may be unilateral or asymmetrical, but most cases eventually consist of bilateral apical fibrobullous lesions, many of which are progressive with coalescence of the nodules, formation of cysts and cavities, fibrosis, and bronchiectasis. Mycobacterial or fungal superinfection of the upper lobe cysts and cavities occurs commonly. Aspergillus fumigatus is the most common pathogen isolated, followed by various species of mycobacteria. A restrictive ventilatory impairment can develop in patients with ankylosing spondylitis because of either fusion of the costovertebral joints and ankylosis of the thoracic spine or anterior chest wall involvement. Chest radiographic findings may be mirror of the severity of clinical involvement. Pulmonary parenchymal disease is typically progressive, and cyst formation, cavitation, and fibrosis are seen in advanced cases. No treatment has been shown to alter the clinical course of apical fibrobullous disease. Although several anti-inflammatory agents, such as infliximab, etanercept, and adalimumab, are being used to treat ankylosing spondylitis, their effects on pulmonary manifestations are unclear. Pulmonary manifestations of Behçet's disease. Behçet's, Behçets, disease, is a disorder that causes blood vessel inflammation throughout the body. Pulmonary artery aneurysms, arterial and venous thrombosis, pulmonary infarction, recurrent pneumonia, bronchiolitis obliterans, organized pneumonia, and pleurisy are the main features of pulmonary involvement in Behçet's disease. Pulmonary artery aneurysms affect mainly young men. Hemoptysis of varying degrees, up to 500 ml, is the most common and predominant symptom. Rupture of an aneurysm with erosion into a bronchus and the development of in situ thrombosis from active vasculitis have been suggested as explanations for the hemoptysis. Sudden hilar enlargement or the appearance of pullobular and round opacities on the chest radiograph can represent pulmonary artery aneurysms. A thrombosed aneurysm of the right pulmonary artery. The fuzzy contour of the aneurysm wall and perianeurysmal consolidation are caused by an acute hemorrhage. Showing multiple aneurysms of different branches of the pulmonary arteries bilaterally. The treatment approach depends on the individual patient, severity of disease, and major organ involvement. Major vessel disease with thrombotic events are treated with systemic anticoagulation in addition to corticosteroids, ethioprine, cyclophosphamide, or cyclosporine A. Pulmonary arterial aneurysms are treated with cyclophosphamide and corticosteroids. Pulmonary aneurysms and areas that incur ischemic damage due to vasculitis or thrombosis may require resection. Autoantibodies in collagen-vascular diseases. Sometimes the classical systemic manifestations of connective tissue disease may not be well defined, or sometimes pulmonary presentation may be earlier than the systemic manifestation. In those cases we can perform the following tests as screening purpose. Take-home messages. Pulmonary evaluation is essential in all rheumatological diseases. Pulmonary evaluation has become more easier with the interpretation of HRCT of chest. If the patient present with DPLD, he or she should undergone screening tests for the rheumatological diseases. End of Part 3. Learning Pulmonology. Thank you. Subscribe our YouTube channel.